Order, order. Welcome to this one-off session of the Health and Social Care Select Committee on Palliative Care. This follows the report that was put together by this panel's independent expert panel, which included clinicians and experts from across the spectrum who looked into palliative and end-of-life care, particularly in England. For those watching along online, you can find that on the Select Committee website. So to interrogate some of the issues that were found in that report, we are delighted to have with us the Minister of State for Care, Stephen Kinnock, MP. Thank you for being with us. And others, if I may ask them, please, to introduce who they are and what they do, perhaps starting with Dr. Sarah Mitchell, please.
Thank you. I'm Sarah Mitchell. I work clinically as a GP in Sheffield. I'm National Clinical Director for Palliative Care and End-of-Life Care at NHS England, and I'm also an Associate Clinical Professor of Palliative Care at the University of Leeds.
Thank you very much.
Amanda Doyle. I'm the National Director for Primary Care and Community Services at NHS England.
Thank you very much. And
Hi, I'm Minister Scully. I'm the Director for Primary and Community Healthcare at the Department for Health and Social Care.
Thank you very much. So viewers watching will understand there is a delicate context in which we are holding today's session, namely the Assisted Dying Bill, which is making its way still through the Lords. And this is not going to be a session about that bill. This is a session about palliative and end-of-life care. And we know that members across this House, in this committee, and indeed across the country, have deeply held views on that matter. But I hope that what we all have in consensus is that palliative and end-of-life care services are simply not good enough and they need to improve. So while, as I say, the session is not about the Assisted Dying Bill, I hope I can ask a very simple question to the Minister. Will he come back one day to this committee, should we wish it, to answer questions about that?
Yes, absolutely. Very happy to do so.
Very kind of you. And for viewers watching, watch this space. But let's wait and see if that bill even passes, let alone what might be in it. So at the top, I understand, Minister, there was something that you wanted to tell us in advance of the session.
Well, thank you very much, Chair. If I could just make a very, very brief statement, which has got some new information in it that I think the committee might find useful. So I'd like to thank the committee and its independent expert panel for their excellent report. Palliative care and end-of-life care plays an essential part in our health and care system, and it is delivered every day by GPs, district nurses, allied health professionals and social care staff in people's homes, hospitals, care homes and hospices. Across the UK, the government as a whole spends over £22 billion a year on care and support for those in the last year of life. In England, this amounts to £9 billion per year on the health-related aspects of palliative and end-of-life care alone. Palliative care and end-of-life care in the UK is world-leading. In 2025, the WHO rated the UK in the top 14% that reached the advanced level of development in palliative care. The European Association for Palliative Care notes that we are one of only a handful of countries which integrate palliative care into all medical school curricula, and we are in the top 5 for specialised paediatric services. We should be proud of this, but we also recognise there is much more to be done. The expert panel report rightly highlights unwarranted variation in access and quality, and we also know that services are too fragmented. I was therefore very pleased to announce to the House in a written ministerial statement on the 24th of November that we will develop a palliative care and end-of-life care modern service framework, or MSF. This is one of just 5 MSFs which demonstrates the priority status of palliative and end-of-life care for our department and for the entire government. The MSF will set national goals and standards for the services that patients and their families receive at the end of life, and it will enable ICBs to address challenges in access, quality and sustainability through the delivery of high-quality, personalised care. We are co-producing the MSF with key stakeholders to ensure that we maximise its potential and galvanise the entire health and social care system. Finally, I wanted to recognise the vital importance of hospices in the broader palliative care system, which is why I'm delighted to confirm today that we are adding a further £25 million to the £100 million capital funding available for adult and children's hospices this financial year. This is in addition to our commitment in autumn 2025 to provide approximately £80 million of revenue funding for children and young people's hospices for the next 3 years. I thank the Chair for allowing me the time to make this statement and look forward to our discussion.
Thank you very much. Well, there's a lot in that, and we've got a good amount of time to dive into the specifics. I wanted to start perhaps with a reflective question, if I may, Minister of State. In your eyes, having been in the job now for, 18 odd months, why has this not happened before? Why is it only now that we're developing a modern standard framework for palliative care? And I hear what you're saying about we're world leading, but Christ, I mean, if we're world leading, I worry for the rest of the world. The bar is low, is it not? Why is it taken, what's changed? Why are we doing this now, and why has it not happened before?
Thank you for that question, and I think it's absolutely clear that there is unwarranted variation. It's patchy. There are pockets of really good practice, and there are areas of the country and also the way in which certain socioeconomic groups and geographical areas are underserved. And we absolutely acknowledge that. I think part of this is to do with the integrated care boards. They have a statutory duty to provide palliative and end-of-life care. That is very clear in the Care Act of 2022. We also then have the model ICB framework, blueprint, which sets out very clearly that ICBs are required to prioritise underserved areas and are required to understand the needs of their population and to serve them accordingly. We also have medium-term policy and planning guidance. We have the strategic commissioning framework. So I think the point I'm making is there's no shortage of guidance, directives, frameworks, but there is clearly a disconnect between all of those documents and all of that guidance and the actual delivery on the ground. The question is that there is clearly, I think, an issue around the capability of ICBs in commissioning. That's why I'm really pleased that we are launching from April 2026 a strategic commissioning development plan to actually talk about and create commissioning as a profession where real skills are needed. We've got the strategic commissioning framework, which sets out very clearly how ICBs need to, first of all, understand the health needs of their population and the context in which they're operating, create a strategy for dealing with that and addressing those needs, do proper strategic commissioning where they work together with partners to address the needs of the population, and then to evaluate the impact of what they've done to create that virtuous cycle. That's not happening. I think we've got too much of a kind of transactional approach to the way that ICBs work and engage with all of their partners in their catchment area, and it's not strategic enough. So the modern service framework is a way of pulling all that together to say, look, we've got to have some clear national standards and goals. We need a national plan. We understand as a government the need to devolve and empower. We believe passionately in devolution, this government, and we can't possibly micromanage everything that goes on around the country from an office in Whitehall or Westminster.
This issue predates, even the current system that we have got now and are changing. I mean, isn't in part the answer here is that there just hasn't been political leadership to make this happen?
Well, I don't want to make too much of a kind of political point here, but the reality is, when we came into office in July 2024, when I looked across every aspect of my portfolio, whether it's general practice, pharmacy, dentistry, palliative and end-of-life care, adult social care, frankly, it was a pretty chaotic disaster across every aspect of my portfolio.
The independent expert panel, when it briefed us about its own report, were genuinely shocked. Having looked, we only commission reports into parts of the system that we think there's a problem in, so we start there. But it was worse than they were expecting. And I suppose I don't think I've quite got to the nub. So you're saying strategic commissioning is the thing, Is that it? In your mind, if this modern standard framework achieves something that didn't happen before, strategic commissioning is one. Is that it?
Well, early identification is vital. I'm quite pleased to see that over the last year or so, we've got quite a good increase of the number of people on the palliative care register. I think it's gone up from 0.46% of the population to 0.55%. About 1% of the population die every year, approximately 500,000 people. And the key is to get more of those people onto the palliative care register, because if you get early identification right, so much more of the system works more effectively. If our big goal is to shift care from hospital into the community, most people want to die at home. We want to support that to happen. All of the health and social care outcomes are significantly improved when people are in the community rather than in hospital. And by the way, it's much better for the system in terms of its efficiency and costs, etc. So early identification is crucial. GPs play a vital role in that. We haven't got enough GPs. I'm very pleased to say, have appointed 2,500 more GPs through the additional roles reimbursement scheme since July 2024. Get more GPs into the field, get them more effectively trained in palliative and end-of-life care skills, so that we can ensure that GPs reach out beyond just core GP practice into those extended roles that they need to play in things like palliative and end-of-life care. Get that interface working far more effectively with hospitals and hospices, district nurses. We don't have enough of them. There's work. Sorry, Chair. You're absolutely right to say it's not only about strategic commissioning. It's absolutely about early identification. It's also about integration of services, and it's about workforce.
And is this going to? Well, thank you for mentioning workforce. We're going to come to that later. Can we talk about money just for a second, so we understand the envelope in which we're working? Is it your view that in order to really shift the dial on this as fast as I think people out in the country desperately want it to shift, that it's going to take more money or not?
I don't think it's necessarily about the quantum, because if you look right across government, we spend about £22 billion on people in the last year of their life. Now, about £5 billion of that is on social security, about £5 billion is on adult social care, and the remaining 12 billion or so is in the healthcare side of palliative and end-of-life care for people in the last year of life. That is a large sum of money. That's about 10% of what we overall spend on the NHS, budget of around £220 billion. So £22 billion as a quantum is a large sum of money. The question is, are we spending it where it should be being spent? And I think the answer to that is a resounding no. We have to shift funding flows out of secondary and acute care into community and primary care. That is, I see that in some ways as kind of the most important aspect of my job. My job is to constantly pressurise the system to make that shift. And I think that the system, there's a baked in tendency for funding to flow into secondary and acute. Power resides in secondary and acute. So if you look at our 10-year plan, that is effectively about culture change. It is about saying we've got to get trusts to let go. We've got to get funding to move from the right to the left. All of that needs to happen through ICBs. Yeah,
but even in hospitals and in that setting where the vast majority of palliative care happens, the service is substandard. So I was speaking to a palliative care doctor over the weekend. They pointed out that in their hospital they're employed basically as a service Monday to Friday, 9 to 5, which is nonsensical for anyone who's ever had a family member have to go through what the services that they provide. So even in that setting, money for palliative and end-of-life care itself is a minnow compared to everything else. And she was pointing out that actually there's even more pressure on it now because of the focus on elective waiting lists and so on. So, where is the money actually going to come from? So you're talking about the quantum that is spent on that, but is it actually going to have to come from other parts within the hospital? Because if they can't even do it 9 to 5 in the hospital, if you're then going to ask that to shift into the community, fine. But the need is so great. That's what the report showed. Are you sure you can do this in the time necessary? And where is that money actually going to come from?
We have to do it. And the point is that we're currently living in a world where the problems that the system is facing, so one of the reasons we have such a huge backlog on electives, is because we haven't made primary and community care work as effectively as it should. We have to prevent avoidable admissions. Far too many people in their final year of life are going into acute care and using the emergency department.
So is your assessment then that the money could be
we've got to be brave and make that happen?
So the same money being spent currently in hospitals on palliative care could be shifted into the community and deliver that 24/7 service that people should be entitled to in their final dying days and hours. Is that your assessment?
Yes.
Have you got the data for that? Because my understanding is that data is not robust.
We have to make that work. That is, I think, that is what the 10-year plan is about. It is about creating a neighbourhood health framework and strategy.
Can we focus in on the MSF that you're... So is that going to be baked into this?
Yes.
Okay.
So the MSF is where, when we talk about strategic commissioning, the funding flows have to follow the priorities that are set out under a new approach to commissioning. So if you're saying we're now going to have a holistic view where trusts and primary care voice, adult social care voice, community care voice are sitting around the table and doing planning in a much more integrated way, that is where the conversation has to happen with the trust to say, listen, if we take some of the funding you currently have and put it into more effective primary and community care, that is going to save you in the long run. It will enable you to focus on the cohorts that you really should be focusing on, keeping people out of hospital who don't need to be in there, enabling people to die a good death at home is good news is a better way for the patient, and it is a much better way to operate the system, both in terms of primary care, community care, and secondary and acute.
So the logic then follows that if you move people out of the beds in hospital into the community, the hospital will then have more beds in order to save money in other areas, and that's how you're going to convince them to move? Because I'm not sure that is what happens, though, is it? I mean, the history tells us hospitals always find something else to fill the bed with. They're not about to take the money out of their coffers willingly. So it's part of this framework. Is it going to have any teeth? Is it going to have bite? How are we going to be able to hold you to account to this?
Every ICB is held to account by NHS England every year. They have to produce...
You're abolishing that. So.
Well, it'll become NHS England, DHSC will become a new body corporate that will do the same thing. It'll be the same function. So every ICB is held to account on that basis. The last outturn on that was January 25, so we will quite soon have... the ICBs have to show that they are discharging their functions. It is our job to hold them to account, and it is your job to hold us to account. So we should be held to account on the basis of what's happening out there in the field in terms of the ICBs, and our ability to hold them to account and to push through the modern service framework and the new approach to strategic commissioning. But I think it's not just about the stick, it also has to be about the carrot. And I think that's what I was alluding to earlier, which is you incentivize the system to change by showing the system that it is to their benefit. To those who currently hold all the power and the resources, which are the trusts, they need to be convinced that it's better for them, it's in their interest to let go of some of that power and resource so that we can push it to the left in the system.
So one of the questions we've got, and I appreciate is it still spring that we're aiming for?
For
the modern standard framework for palliative and end-of-life care? What's the timeline?
There will be an interim report on it in the spring and finalisation in the autumn.
What will be in the interim report?
That will be an update on the progress that we've made. So far there's been 5 meetings between officials and the large number of stakeholders that we're reaching out to. So that's going to continue January to April. There will be regional level engagement to include systems and providers. Spring 26 interim update on MSF development. Autumn 26 publication of the MSF.
Autumn 26. So that's the point what we'll see. And in there we're expecting high-level statements, targets, incentives, everything that you've spoken about.
National standards and goals.
National standards and goals.
Yes.
Is there going to be an actual smart timeline to it? I mean, when will people start to have faith that this is changing for the better? I appreciate, a 10-year plan says what it says on the tin. It's a 10-year plan, I get that. But I think people out there want to know, if this happens to them, next year, in 3 years, in 5 years? What is the point where they can look across and go, actually, I can breathe a bit because it's just not going to be in the same dire state it is now? What's your hope for that?
Well, I'm very conscious of a parliamentary timetable. I think we have to be able to demonstrate very clearly by 2029 that we've seen a step change in improvements to palliative and end-of-life care in our country. That by step change, I mean we need for people to be confident that they will be identified early as being in the last year of life.
I mean, are you measuring unmet need now, fully?
Yes, we think that there's about, if you measure it on the basis of, if you're on the register of palliative care, there's about 345,000 people on the register of palliative care. That is only about 50% of the total number of people who are in the last year of life, if we assume that there's about 500,000 people at any given time in the last year of life. So unmet need is, if I would like to be in a position where we've got 90% of the people who are in a last year of life on the palliative care register. We're clearly quite a long way from that. 30 or 40% off it. So that's a stretch target that we need to do everything that we can to achieve. As I said earlier, GPs are an absolutely crucial part of that, because that's where the process starts.
And it brings me quite neatly onto social care, because one of the big areas that, of course, you'd expect very good end-of-life and palliative care in is the social care setting, but very often it isn't there to the level that people would necessarily expect. What is your plan to integrate this with social care?
We accept that there isn't good enough involvement with and interface and integration with adult social care.
Is this going to be covered by the framework? Are you consulting with social care settings?
Absolutely. So if you look down the list of stakeholders that we're engaging with for the modern service framework, we've got people like the Social Care Institute for Excellence. We've got the Skills for Care, the National Care Association Alliance. So we've got a whole range of the key players. We don't have that
list. Could we get a copy
Absolutely,
of it?
very, very happy.
That would be really helpful.
Yes, with pleasure.
Thank you very much.
So we recognise that voice needs to be heard. Obviously, local authorities play a crucial role in that. So, we've got to ensure that local authorities are around the table as we develop this modern service framework. We want also to look at ways in which care workers can be more empowered. We're looking at delegation to enable care workers to do more things like some healthcare checks, blood pressure checks and that sort of thing. So we think there's a big opportunity for care workers to really be brought much more effectively into the picture, and we recognise that has not been happening to the extent that it should hitherto.
Thank you very much. I'll now pass, if I may, to Ben Coleman.
Yeah, no, thank you. So just I was very good to see you all today. Thank you for coming. May I just ask a little bit about ICBs? If you want local authorities, just to pick up on the point that you were talking about with the Chair, if you want local authorities to be more involved in developing palliative care service and other services, why is the government planning to reduce local authorities' roles on ICBs, reduce the numbers of local authorities that sit on ICBs?
I wasn't aware that we're planning to do that, but
it was the paper, the name of which escapes me, which we discussed at the committee with before Christmas. And they're talking about only mayors would be on ICBs. I mean, at the moment in North West London, you have 3 councillors on sitting on the ICB, which is unusual. Had to fight for it and got it. Other places it's 1 or 2. But you're merging ICBs. Obviously, the North West London is merging with Central London. So, and there's no plan, as far as I'm aware, to increase local authority involvement. Indeed, there's a plan to reduce it. If you haven't got the answer today, and I appreciate you may not, would it be possible for you to write to us and let us know how reducing local authority involvement in ICBs will help with the sort of aims and ambitions that you've just set out of involving local authorities more in delivering better palliative care and, I presume, other services?
Very happy to do that. And, I think we're looking, for example, at reforming the Better Care Fund, which plays an absolutely crucial role in terms of bringing local authorities together with the health system to improve delayed discharge, which is a massive challenge that the system's facing. So I think that's been happening. I have been working on that with my officials and with MHCLG officials very, very closely. Yeah. So I would say that at least at the level of what's happening in Whitehall, the interface between DHSC and MHCLG on things like reforming the Better Care Fund has been working very well. We need to make sure that cascades down through the system. So your point is well made and well taken.
Yeah, I mean, it's the 10-year, just checking my notes, it's the 10-year health plan that talks about mayors, or strategic authority mayors sitting on ICBs rather than local councils. Well, we don't have a strategic authority mayor in London who does that, and there are other parts of the country where it might not be appropriate. I think it's one of the weaknesses of what's otherwise a very impressive 10-year plan, the continuing misunderstanding of the role of local authorities and the lip service, which is delightfully and importantly paid to their importance, but actually on a practical level, the things which are done or not done. Can I just ask you, if that's just a general point to make, if you forgive me, on the Better Care Fund, which you raised, what is the main problem at the moment that you're trying to solve, that you say you're engaging quite closely with?
Yeah, I think it's about early engagement and planning between the health system, from all the way from primary and community care through to the trust and then to the local authority. So it's how do we make it clearer that the focus has to be on getting that early engagement and getting then the Better Care Fund. I mean, it's a big fund. It's £9 billion to deliver improvements in delayed discharge. Yeah. There's also going to be some new. I mean, I can't say too much about it because we're launching the new and reformed BCF in the coming months. But one of the key things is around preventing avoidable admissions. So it shouldn't just be about, if you like, the back end of the system where where we accelerate delayed and tackle delayed discharge. It's about stopping people going into hospital who shouldn't be there in the first place.
That's absolutely, and that's actually better prevention. Obviously, being one of the three drivers, and it works much better.
Yeah.
My experience of the Better Care Fund, and I appreciate I've been a member of Parliament since July last year, and so things may have moved on. Was that it's the NHS dictates to local authorities what's going to happen. There is a sort of negotiation, but it happens very late in the day, and then the NHS can even pull the plug on what's been agreed at the last moment. And it's, of course, there is a difficulty also in the NHS timing for its financial time, its funding is different from local authorities. Are you addressing all of that? So it actually, local authorities, have you been discussing, for example, your new plans with the directors of adult social care?
Yes.
And they're on board with
I have a regular, I think once every 2 months I meet the head of ADAS and the head of the LGA jointly, and we talk, the BCF always comes up. Yeah. There's good practice. I've recently visited a hospital in Bradford where they had a delayed discharge team which was made up of a combination of hospital staff and local authority staff sitting in the same office in the hospital. And they had almost a kind of airport-style screen up with...
No, that's brilliant.
And they were just totally integrated. That's what we need to get to. Yeah.
But the funding, the problem with that is not that sort of system approach, which is really effective and happens also in local hospitals to me. But it's the funding that local authorities know that they can provide and they can plan ahead for. The problem there is the NHS has a different timetable for its funding, its budget has different start and end points, and it also still has so often takes this de haut en bas, this top-down approach. We will tell local authorities, we will call them partners, but we will tell them what to do. And I'm a little concerned that if that doesn't change, whether it's palliative care or other things, we won't really get the most out of the relationship between local authorities and the NHS. It's not genuinely more egalitarian.
Yeah, I completely agree, and I think this is part of the culture change that I was discussing with the chair earlier, is how do you create a integrated approach? I think that the neighbourhood health framework will help for that, because that's about, if you like, almost starting with a blank sheet of paper and saying we now need to do away with all the old power structures and all the old sort of funding flows and move to a system where a neighbourhood health and well-being approach, which brings in GPs, community care, local authorities. Everybody needs to be around the table to make that work and make that happen and deliver that at a neighbourhood level.
Oh, that's very helpful, and I completely agree with you. That as a conceptual approach, that's exactly, I very much support that. How can you get round, because you made some very interesting comments about your experience of coming in as a Minister for Health and dealing with the situation in the system as you found it. How keen are you to overcome this this blockage in the relationship where effectively NHS still thinks it's its job to dictate to local authorities what happens, and it's local authorities' job furiously to try and stop being bulldozed by the NHS?
I mean, I think it varies from area to area. We do see some examples of ICBs, if you like, winning the argument with the trust, and the trust accepting.
The ICB itself is so often the problem, because it's the NHS. There is one or maybe two, in North West London 3, but that is going to change, as I say. The 10-year plan wants to reduce the already rather small presence of local authorities on ICB. So the ICBs are effectively NHS organisations which tell local authorities as well what to do. They're not part of the problem.
Yeah.
But ICBs have to be an umbrella organisation which looks at primary care, community care, secondary care and acute care holistically and on a level playing field, not where you just continue with the business as usual approach of favouring secondary and acute. Well, if that continues, the 10-year plan will fail.
Are you looking
That's
as a department?
absolutely clear.
Amanda, sorry, I can see
Yeah.
she wants to.
No, do you want me to?
Yeah.
So I think it's important that the reform that we're talking about of the Better Care Fund is about enabling consistent, effective, joint planning and commissioning and funding of services across health and local authority. We've got a bunch of services that are clearly almost entirely health and a bunch that are clearly entirely local authority. But we've got this huge overlap area in the middle whereby if services are not integrated, if they're not jointly planned and commissioned, they just don't work for people and patients. And palliative and end-of-life care is a clear example of so being able to properly link up health support services with domiciliary care services, for example, so that the default for people is not calling an ambulance because a care worker or a family member doesn't know what to do. People don't call ambulances because they think they're
I'm a little bit lost. Are you saying that they don't know what to do because they're not properly trained?
Not because they're not properly trained, because the services are often not very integrated and coordinated in a way that everybody knows how to pull on the support that's available. And so what we get is disjointed services. And the approach through the Better Care Fund should be jointly planning those services so that both health and social care staff and, importantly, families and carers know how to access support at home, so the default is not an ambulance. And so this is about linking in domiciliary care services, adult social care services, home care support, the voluntary sector support, things like night sitting, with not only primary care, specialist palliative and end-of-life care services, and some of the other range of services.
And I understand that, and I'll just to clarify, I understand that. That's all what's on paper. But in practice, the NHS tends to say what needs to happen in a really quite unpartnership focused, if I can use horrible jargon or normal language, dictatorial way. Are you aware of that?
I'm aware of places throughout the country where there are less functional working relationships and where things aren't planned jointly as effectively as they might be.
Thank you.
Yes.
You don't see at the top of the NHS a challenge, an intellectual challenge in respecting local authorities and working with them on a genuine partnership basis, as opposed to, well, we've got to get them in line as well as everybody else. It's about how you start thinking about a problem and who your partners really are, and whether there's any equivalence there, or whether you've just got to drive things through and they've got to do what you think, in the way that you've described, makes sense.
I think we all accept that this needs to be genuinely approached in a partnership.
What would you change in the way the NHS thinks and behaves when it comes to local authorities to enable that, when it comes to palliative care or whatever area, become better?
The ICBs, as the strategic commissioners and conveners and working in partnership with local authorities, should absolutely be thinking in terms of those wider local partners as they develop neighbourhood health services.
Will you check whether they're doing that properly?
That's part of how we will assess ICB's delivery of their statutory functions, yes.
Thank you very much. Thank you, Chair.
Thank you. Dr. Becky Cooper, please.
Thank you, Chair, and thank you for being here. I'm just going to just finish up Ben's point around integration. So if I just look at some of the evidence that our expert panel had, I mean, none of this is going to come as a surprise to you, but, you know, patients and families reported encountered a complex, disjointed system which led to delays and gaps in care. And they found that only a quarter of published integrated care strategies referenced bereavement at all. And that over 40% of people who wanted bereavement support in England were not able to get any. So I suppose sort of my first question, just to finish up the integration point, is do you think it's appropriate that all integrated care strategies should reference bereavement, end-of-life care, have a specific area that actually says what they're going to do?
Yes, I think...
So a quarter is simply unacceptable. To find 25% of integrated care strategies, that's unacceptable.
Yeah, absolutely. I think, you know, bereavement support is absolutely vital. We've got things like universal principles for advanced care planning, and I think advanced care planning is the key to a lot of this, because if you get that early identification to work, you start to have those conversations with the patient, with their family, with their carer, so that you've got that personalised, patient-centric approach, sensitive conversations happening about how they want to be treated, how they want to be cared for, where they would like to die.
Absolutely, Minister. So in order for frontline care professionals to do that, you would agree that integrated care strategies should reference bereavement and this strategy, not just have a quarter, as our expert panel found.
Absolutely. I see no downside whatsoever to getting to 100% on that.
Excellent. So if I can just move on slightly and ask you what plans the government has to increase and improve out-of-hours palliative and end-of-life care services. This came up as a serious issue.
That is going to be one of the key points in our modern service framework. So we want to set national standards and goals for example, looking at having a 24/7 telephone line available everywhere across England at least.
And currently, what's the coverage of that 24/7 helpline, just to remind us?
I think it's about 24%.
20, so less than a quarter.
Is that right? That was in the Hospice UK have done a report. And you know, it's really clear that having that 24/7 telephone line would be extremely beneficial. Coverage is not where it should be, so that's going to be something we're looking at in the modern service framework.
Of course, and over what timeline would we expect to see 100% coverage?
I hope that if we get the modern service framework up and running, published by the autumn of this year, we'd be looking at implementation then in 2027.
2027,
yeah.
Excellent. And in terms of staffing the 24/7 helpline and other human resources that will be necessary to allow sufficient end-of-life services out of hours, where are you in terms of the national health workforce and putting in place plans to ensure that it's adequately staffed?
The workforce piece is complex, obviously, because so many people are involved in palliative and end-of-life care. You've got GPs, district nurses, specialist doctors.
So I think we're going to come on to the specialist workforce. I think my colleague's going to ask about that, but I was just specifically going to look around the out-of-hours care, because that is an issue across the National Health Service. We're not a 7-day-a-week health service. And in this particular instance, do you see that this could actually pose a serious problem for out-of-hours care?
I haven't done the modelling yet of what kind of workforce would be required to staff that telephone line, but it would be a single central number. So one would assume that it wouldn't have the enormous staffing issues. Clearly, the round-the-clock nature of it would require some thought and make sure that we staff it properly. There's absolutely no point in us saying we want to commit to around-the-clock telephone service without being able to staff it. So those two things have to go together.
We'll look forward to seeing that modelling at the earliest possible opportunity. Excellent. So if I can just move you on to data collection. So this was something that our expert panel identified as a key barrier to understanding population need for end-of-life care, and it is a recurring theme for this committee. Regardless of who's in front of us and what we're talking about, data collection and sharing seems to be extraordinarily poor across many aspects of the health service. So what plans do you have to improve data collection in this particular area?
I think there are tools there that are not being used properly. We have the palliative care dashboard. I would be very happy to share more information about the dashboard with the committee, and I might actually ask Dr. Mitchell as well to talk a bit about that. She's very much leading on the clinical side. I think the dashboard is a powerful tool because it provides an ICB by ICB breakdown, looks at how many people in the ICB area are dying at home, how many people are dying at hospital, how many people are dying in hospices, etc., and then looks at the outcomes for each of those. And that, I think, really helps to inform ICBs. The problem is that the patchy use by ICBs, some ICBs I think are really leaning into the dashboard and others aren't. You've also got client-level data for adult social care, and I don't think we're doing enough to really utilise that data to bring that into our thinking about how palliative and end-of-life care is working across the country.
Okay, so if I could just ask Dr. Mitchell,
and
would
then
you like
Dr.
to...
Mitchell on the
Thank you.
Yeah.
Thank you. So the Palliative Care and End-of-Life Care Dashboard has been developed by NHS England, and it's intended to be a resource.
Sorry, when was it developed? Can you just tell us?
It was developed and first launched in 2021.
Okay.
And it's a dashboard that brings together existing data sets. So we use the palliative care QOF data from general practice, which has existed. We have hospital episode statistics and death data, so that the dashboard provides information which can be broken down by ICB to give numbers of patients who've been identified in primary care as having palliative care needs or being at the end of life.
Okay, and sorry, just to move you along. So the ICB data that are collected, the Minister said that it was patchy. Are you able to give a percentage of how many ICBs are actually contributing these data?
That dashboard covers every ICB.
So every ICB so have you got any gaps in your data collection on this dashboard?
The dashboard makes use of the data that exists, that we have. So it's retrospective data. I think
let me try this question again. Are there data missing in this dashboard that you would want?
We would like to see more data to understand current patient need related to the complexity of need and also to those population trends. And I think the population health management tools that are being developed and used in ICBs give us that more live data.
Okay, so I don't know if this is for the Minister or yourself, Dr. Mitchell, but this palliative care dashboard currently, what does it allow you to do in terms of planning service delivery now? And what would you need in order to make that more effective?
The dashboard would give us information about trends in an ICB area. So it gives us information about the age of death of patients, their socioeconomic background. It also gives us evidence on associations between where people are dying and their use of healthcare services. So it breaks it down so we can see their rates of attendance in the emergency department, followed by urgent and emergency, admissions to hospital, but also outpatient activity. So it gives a sense of trends which should be informing our healthcare service design.
So using those trends, are population health experts able to model future need and requirement? Is that something that they can use those data for?
I think that data would be part of a suite of tools to model future need.
But it's currently not being used to model future need.
I think it is being used. I couldn't tell you exactly how many ICBs are using it, but we are working through our regional colleagues with the ICBs to highlight the importance of all of that data.
So is it fair to say that it's unclear currently whether the ICBs and their population health colleagues are utilising the data that we have efficiently and effectively? It's unclear currently.
It's unclear. However, I will say that some of the ICBs have got spectacularly advanced dashboards that can
well done then.
down.
Excellent.
Yeah.
So what we'd want is all of them to have that.
Yeah,
excellent. So going back to the Minister, there are plans to improve that, I think, holistic approach so that all ICBs are outstanding. Is that right, Minister?
Absolutely. That's what the Modern Service Framework will be about,
okay.
And our approach to strategic commissioning, because strategic commissioning will not work unless you're using the data properly, because it's a population health management approach, and you can't develop a strategy unless you've really got that data. The other thing I would add on data, the Policy Research Unit in the NIHR is doing a deep dive on inequalities to try and give us much more robust data on inequalities.
Okay, great. So it sounds like there's room for improvement in usage of data and perhaps understanding all ICBs. Thank you so much.
Yes.
Thank you, Chair.
Thank you very much. Alex McIntyre, please.
Thank you very much. So I'm going to come on to advanced care plans. And the expert panel found that even when there were advanced care plans in place, that people were often unable to access their preferred services due to the limited resources or inflexible clinical pathways. What are your visions for the future of advanced care planning?
Yeah, thank you for that. I think we've got principles for advanced care planning. It's the Universal Principles for Advanced Care Planning, published in 2022. They focus on the importance of providing opportunities for a person and their family or carers to engage in meaningful discussions led by the person concerned that consider the person's priorities and preferences, including place of care and treatment choice when they are nearing the end of life. So there's no argument about the theory. And that's probably a bit of a red thread that goes through all of this conversation. I think we have frameworks, we have principles, we have guidance, we have documents and plans. The question is execution. And I think that's where early identification is absolutely crucial.
Really sorry, Minister, to interrupt, but if someone's got an advanced care plan in place, they've been identified fairly early, and yet they're still not being provided with the service that that is intended. So what's the gap there? Is it just that, and we can fall back on commissioning, but presumably if they're well advanced enough to have an advanced care plan, they've been going through the system, presumably services have been commissioned, but then there is a stop at that point. They're not then getting access because of either resources or clinical pathways not being there. What's the answer? Is it more resources that's needed at that point?
I mean, I think there's two issues. One is that we don't have enough people on advanced care plans, and that comes back to the identification point, the point about, 345,000 people on the palliative care register. We want there to be more. You're not going to get an advanced care plan until you're on the register. So the first step is to get more people onto the register. A lot of that is around improving the way in which GPs are working and also increasing the number of GPs, which we have done. So I think that's an important aspect of your question, is the coverage in terms of advanced care plans. And then your question is very much about the quality of the advanced care planning process once somebody is on that pathway. I think that there's, in terms of improving the quality of the workforce around that, we've got training tools. For example, the ELCA program, I always forget what it's called, End of Life Care for All program, which is a program that actually has good take-up in terms of the number of people that are doing that training course, and that is all about training the entire system around how to be better at having those conversations, doing end-of-life care.
I think one of my colleagues is going to come on to workforce later on in the session. So, just to move on slightly, how do you see bereavement and other support services for families and loved ones and carers fitting into the framework for palliative care going forward?
Can I maybe just ask Dr. Mitchell to add anything on the advanced care planning? Because I think there's more to say on that.
I think it's just really important that we're clear that the evidence around advanced care planning as a discrete intervention is quite mixed and variable, and that patients are, these are patients who are so vulnerable and living with highly complex and dynamic needs that can change unexpectedly. So even with the very best advanced care plan, there might be a clinical scenario that we haven't foreseen, that we need a change of plan. The most important context for the care planning process is continuity of care delivered. We see a strong association. The evidence is compelling that there's an association between continuity of care with primary care and the wider multidisciplinary team, including specialist colleagues, and reduced use of urgent and emergency care towards the end of life. It's about trusted relationships and a way to manage those changing care needs as they go. It's really important that's understood.
So and we'll move back to my previous question. So bereavement, other support services, how do they fit in with the model service framework?
There was a report on bereavement, I think in 2022, called Bereavement is Everyone's Business. And after that, the department established a cross-government bereavement working group to ensure better collaborative working across government departments. I think, the question is the extent to which that working group is effectively improving the way that we do bereavement support across the system. And, it's an absolutely vitally important part of the way in which palliative and end-of-life care is both about psychological support and socioeconomic issues, as well as it is about symptom management and control. The question is the extent to which we're getting that right in terms of bereavement support. I find that it's quite difficult to measure because, by definition, the kind of bereavement support that a family might want can vary hugely according to the cultural context, the psychological situation in which they find themselves. The whole, if you like, the grieving process is very subjective. So it's quite difficult to measure the quality of those bereavement services. But I don't know if colleagues wanted to add something to that.
We would consider bereavement care as a public health issue, and we know that the impact of bereavement on on carers and relatives can be profound. We tend to split our thinking about bereavement services into three levels, with the first level being about preventive measures. So that would fit with my continuity of care piece, that if we're providing compassionate care and doing some pre-bereavement work with families, we then can help them through the whole care at death and the death processes afterwards, which include the interface with the medical examiner system, and they have good practice series which includes care for bereaved relatives. Level 2, which would fit for about 30% of the population, targets those at most risk of complicated bereavement, and there's lots of innovation around the country about how we can be proactively identifying those people where there might be a risk of complicated bereavement, and working with volunteers, for example, compassionate community approaches, and our voluntary sector partners.
Complicated bereavement?
Pardon?
What's complicated?
Complicated bereavement.
Your definition?
Is about 10% of people. So those are people who are more likely to have prolonged grief disorder, so their grief goes on for a very long time, can have an impact on their health and well-being and their ability to work, for example. And complicated grief is those associated with, really, really strong mental health problems. So we would need to work collaboratively with our partners in mental health to ensure that those services are available for our patients.
Winced because we've recently done a report on that.
No worries. Thank you for that.
Can I just come in quickly on bereavement? There's three things I was going to say. Statutory guidance from NHS England to systems, which is by the 2022 Act, they should kind of deliver, sets out that everyone should be providing bereavement service. Now, clearly that's not happening everywhere. There is a bereavement quality survey that we can share with you, we can share the findings, but the department on the back of that and on the back of the commissioner, the Minister talked about, undertook some research that we plan to feed into the modern service framework. So it's something that we're really actively thinking about. That's what.
Thank you. Moving on to death literacy. The panel found in their report that society has generally got quite low levels of that, meaning that there's very limited understanding and as my wife will attest to, a reluctance to engage in conversations about death and dying. Is this an area the government is planning to do any work on?
Yes, I think that it's right that as a country we don't talk about death enough, and for all sorts of perfectly understandable reasons it has a certain stigma around it, and people don't talk about it enough. I think there's two sides to the coin. One is the system and the workforce, and then the other is the public. Probably a bit easier for us to talk about the former than the latter, but I think it's interesting as well to think about how we might get the public more engaged on this issue. From the point of view of the former, about the workforce, there is the death literacy, bereavement counselling is part of the ELCA training programme that I mentioned earlier. We also have for adult social care workers, the Learning and Development Support System LDSS training programme, which also includes modules on death literacy, if you like, bereavement support. And there are pockets of good practice. There's a project called Compassionate Sheffield, which is St Luke's Hospice and the local authority, I think, and the ICB. And that is just looking at this whole issue of how do we change the conversation around death and make it something which is a kind of a, almost like a social and cultural conversation about, how do we plan for a good death? And that doesn't happen unless conversations take place between the individual and their family and their carers and the providers of support, whether that's through domiciliary care or a hospice or, if necessary, in hospital. So I think it's looking at things like the Compassionate Sheffield project and saying, why isn't that happening more widely across the country? With regard to improving the way we talk about it across the public, I know, Chair, we're not here to talk about the assisted dying bill, but I would posit that one of, whatever our views on assisted dying are, one of the byproducts of the tremendous amount of attention and debate that has been generated by the bill has been more of an increase, I think, in people having conversations about dying and planning for death. And whatever our views on the bill, I would argue that that's a good thing.
May I say one more thing? I think this is really important, the death literacy conversation, and I think it's particularly important because we have got data from the Policy Research Unit to suggest that we haven't got a great understanding of what palliative care is amongst the public, particularly people, compared to white people, people of Asian ethnicity and those of Black, Caribbean and African ethnicity are less likely to be aware of palliative care, have the correct knowledge of palliative care, or trust our healthcare systems to deliver it. So this will be a really, really strong theme for us to be considering as we develop that MSF.
Thank you very much. Andrew George.
Thank you. So we all agree, of course, that it's better to shift from hospital to community. People want to be treated closer to home, not further from home. But what the expert panel found was that that it would be completely inappropriate to shift the burden of care in relation to palliative care into the community unless there was sufficient planning and resources were in place. So you've got the MSF, which is due to be, one assumes you mean implemented in the autumn. I mean, how close are you, or rather how are you going to ensure that palliative care can be, and you have the capacity to deliver more palliative care in community settings going forward?
Yes, thank you for that question. I do think it sort of pivots back to what I was discussing with the chair earlier, which is that we have to make this happen, because otherwise we're just going to see a prolongation of the status quo. The question is how to make it happen in a way that still enables the stability and sustainability of the system. So obviously, if you just were to pull the rug out from under secondary and acute care and say, right, we're slashing your budget overnight and we're putting it all into primary and community, that would seriously jeopardize the stability of the system. So I think it has to be a gradual and managed change and shift, but the first step on that road is to define the model of care that we want, to define that future vision and picture of where we want to be. The 10-year plan does that. It says we're going to shift from hospital to community, we're going to shift from treatment to prevention, and we're going to shift from analog to digital. coming down from that, we're going to have a neighbourhood health approach, which is going to be the way that we enable those shifts, particularly the hospital to community shift. Once you've got all that model in place, then the money and the resources has to flow from that. You've got to define where you want to go first.
So we've been through the model. We understand the model. We understand the 3 shifts. We've been through that many times before. But the workforce isn't there. I mean, the workforce has declined in the last decade. And after all, 130 of the 168 hours in a week are out of hours, and the community needs to. And people needing palliative care need to have those specialist services delivered to their homes. Whether it be hospice at home, whether it be the hospices themselves, those resources are simply not there, and the staff are simply not there. So you're a long way from being able to deliver the palliative care that you're talking about in the MSF, aren't you?
On the workforce piece, I think there's sort of 2 sides to the workforce in palliative and end-of-life care, the specialist side and the generalist side. On the specialist side, we have actually seen quite a significant increase in the number of specialist doctors. I believe that has increased. I think we're at 910 specialist palliative care and end-of-life care doctors now, which is an increase of 40 since 2024.
78 vacancies in senior consultants and 55 retirements expected very soon.
In specialists, doctors,
yes. So yes, you're putting a brave face on it. It's still not good though, is it?
No, but it's increased. I mean, if you look at where it was, say, in 2010, I think it's been about an 80% increase in the number of specialist palliative care doctors since 2010. And about a 5% increase since 2024. So there is some increase in the specialist workforce, not where we'd like it to be. I absolutely accept that, but that's sort of been moving in the right
What's the
direction.
number you want?
I don't know the answer to that question. Do we have a?
We don't have a number. What I think is important.
Don't have a number.
I think that's part of the long-term workforce plan modelling.
Yeah.
That's part of that, and that's.
We're going to come to specifics
I mean,
around how
it
you're
seems
working
to me
it out.
that the specialist consultant is running at about 10 per million population. I mean, is that the target? Is that the right ratio, or should we be higher than that?
Well, as Ed says, we're publishing our workforce plan in the spring, and that will right across the board set out what our targets, and that's why I don't know the answer to that question yet. But it's important that we have a strong specialist care capability. From the point of view of the generalist workforce, quite difficult to define because, of course, it just cuts across so many different aspects, from GPs to community healthcare, district nurses, adult social care. But if you look at the GP side of it, of course, we have hired 2,500 more GPs since July 2024. So I think we're moving in the right direction on that aspect of the generalist workforce, but I absolutely accept there's still a long way to go.
I mean, there's been a fall of 5% in community nurses in the last decade. And just coming down to the practicalities of providing palliative care in the home, just setting up a syringe driver and the titration and so on involved in that, I mean, that can't be done by a care worker. It has to be done by a qualified, competent, registered nurse or nurses working in tandem, and there just simply isn't the workforce there to be able to provide that level of care in the home at the level that is required. Is that not right? Am I wrong in that?
I mean,
No, you're not wrong. There's a significant need to increase the capacity of the community nursing workforce if we are going to succeed in what we say in the 10-year plan. And the cohorts we're asking ICBs to focus on supporting out of hospital first are those with severe frailty and those at the end of life, which includes the services we've been talking about. It's absolutely key that we have a community nursing and primary care workforce who can support those patients, and that's what the left shift is going to start with. Right. But we do need to ensure that along with the patients and the services that we deliver to them, that we pull the funding from the acute sector into primary and community care services in order to build that capacity.
And just to give a bit of context on specialist palliative care, in terms of the overall cost of treating people who are dying or in the last year, it only accounts for 6% of overall spend, because the vast majority is generalist care. So it's I know it's still significant, but it's 6% of the overall spend.
No, I understand that. But just before the shift happens, we have to make sure that the baseline within the acute sector is coping with the demand there, and yet, as I understand it, a large number of acute trusts have been forced, because of the ironclad financial constraints on those trusts, that there is a recruitment freeze across a lot of those trusts. I mean, is that something which you, Minister, could look at and perhaps loosen those restrictions, because at the present time there are a lot of vacancies, there's a lot of recruitment freezing going on, and therefore services are under a tremendous amount of pressure. So you can't shift until you get the baseline, under control and safe.
Yes, it's absolutely a priority for me to enable the shifts that we have in our 10-year plan. I mean, the 10-year plan depends on, if we're going to operationalise it, resources are a really important part of that. But I do think it's also about reforming the system, and through better integration, through better use of technology, you can, I think, be more productive without necessarily needing significant increases in headcount. So I think I absolutely accept the basic premise of your argument, which is if you're going to change, you have to resource that change. But I think it's not just about headcount.
To clarify, I believe what he's not talking about is increased numbers. It's simply that if people are leaving for maternity leave, they're retiring, long-term illness, whatever, my understanding is the acute trusts are not recruiting behind. And so what you've actually got is not more based on a headcount. They've already assessed what they need. It's that they're not recruiting behind people who are leaving for natural attrition because of retirement, or indeed because of maternity or long-term sickness. I mean, that strikes me as deeply worrying for a system that is so under pressure and under-delivering based on the report. Wouldn't you agree?
I think there's a statutory duty for trusts and ICBs to deliver the best possible care to their population. So they need to ensure that they are discharging their functions on the basis of those statutory duties.
But you're sending them two messages. One, work within their budgets, and on the other hand, saying that they mustn't engage in recruitment freeze. So the two things don't add up, do they, at the moment? I mean, you've left them in an impossible position.
I'm certainly not arguing that it's not challenging. I do think if we look at, for example, the progress we're making on getting the backlog down, and even in the face of industrial action, some pretty impressive results there on electives. That, of course, has cost a huge amount of money. £250 million is what that strike has cost us. Yeah. So, there's a huge pressure on the system. I do accept the basic premise of your argument, but I also think the quantum, the financial envelope we have is what we have. We have to work more smartly within that. But I don't know if Amanda or the team wanted to add anything.
We are not directly instructing acute trusts not to employ clinical staff where they need them. No. They do have a responsibility to live within their means, to balance their budgets, as well as their responsibility to deliver appropriate care for their patients. But individual trusts are taking individual decisions about how they balance those two responsibilities.
Okay, right, point taken. We've highlighted the issue. Just shifting across to capacity elsewhere, and particularly the hospices. I don't want to sort of tread on toes of my colleagues and ask about the funding of them, but the fact is that it doesn't appear that the NHS and the hospices seem to be as integrated as they could be in terms of providing a seamless relationship in terms of care. And if there are, the one in my area, Cornwall Hospice Care, gets 9% of its funding from the NHS, and is struggling. My colleague will come on to the wider issues, but how can you shift from from acute care out into the community if you've got the people out there wanting to help you not being given the support that they need.
I very much hope that the hospice in your constituency has benefited from the additional funding that we've put in terms of is it an adult hospice
yes,
or
it
children?
is.
Yeah,
yes, it's been the Cornwall Hospice Care, St Julius as was, but of course it's been hit by the national insurance increase, which cost them £250,000 a year on their turnover. So it seems to be a balancing message really at the moment, but certainly one which puts them under a lot of pressure.
Yeah, we recognise that we're doing what we can to support hospices through with the extra 25 million I announced today earlier on in this session, and the £80 million for children's hospices. Clearly, hospices have got that independent role, which I personally think is a good thing, and most hospices welcome it. It gives them a lot of flexibility to provide all kinds of services that you wouldn't get on the NHS, and they're so embedded in the community and all the kind of fundraising that goes on around it. I think they're a huge asset in the community, and their independence helps. So I personally wouldn't support, I know some people argue for hospices being 100% funded by the NHS. I personally wouldn't support that position, and the government doesn't support that position. Nevertheless, we need to ensure that they are an integral part of the strategic commissioning process. So a big part of the MSF, and you'll see when you get the list of all the stakeholders that we're engaging with on the MSF, hospices are front and centre and are going to play a crucially important role in shaping that, so that when we get to commissioning, when we get commissioning to where we need it to be, that the commissioners are fully cognizant of what the hospice in their community can provide, and they are receiving funding accordingly to deliver those activities.
Yeah, okay. I mean, it was about the integration rather than the funding.
I just add a bit on the integration.
Yes.
So I think it's different in different areas. So I think, for example, if you look at some of the good examples, like in Leeds, as part of the West Yorkshire Collaborative, they are all part of the shared care record, the two different hospices in Leeds and all of those in West Yorkshire. Mm-hmm. And somewhere like St Francis in Berkhamsted, which is actually commissioned by Community Health Trust, that shares all the records. I know that's not the case in every area, so I think it's different in different areas, and the challenge, I think, as part of the commissioning bit is how do you pull everyone up to that bit where you've got the really good ones that do operate seamlessly, but not everywhere it does.
No, I mean, looking at it wider, it's about, or the fear is, and I think from a patient and family point of view, is that yes, the shift out of the community, but to a certain extent there's a fear of, well, out of sight, out of mind. They'll feel safer in the hospital, given that there isn't the 24/7, access to medication, access to advice, access to specialist palliative care when needed, and therefore you will get the avoidable admissions into the emergency department, won't you? I mean, how can you be sure that there is the integration there between services in the community?
The way to ensure that is to have a modern service framework that effectively works, and is where you've got a very clear national standards and goals, and every ICB is crystal clear on how they should be achieving that, and the vital role that hospices play. I mean, when you look at the statistics, I think about 40% or so of people die in hospital, 28% die in at home, and something similar in care homes. About 6% of people die in hospices. What we do see very clearly from the palliative care dashboard is the people who are at home and being looked after in the community are far less likely to go into hospital, into emergency care in that last year of life. So there's also a very clear connection. It's much better for the hospital and for the system more broadly for people to be at home or in the community in terms of the downward pressure that exerts on avoidable admissions.
More so than a residential home. So there will be admissions to hospital. Is that?
The association, it's an association, so there's fewer admissions from for people at the end of life at home and in care homes. It's a trend, though, in association.
Gradual diminution, you mean, of numbers and proportions that are admitted? You mean?
Yes.
Okay.
Yes.
It seems to be contrary to...
The closer you are to the community, the less likely it is, the trend shows from the dashboard, the less likely it is that you'd have to go into emergency admissions.
Okay. Right. Yes.
I'm pleased you mentioned medicines, because I think it's worth highlighting the important role of community pharmacy in this. So we know the interventions that make people less likely to have an emergency admission. It's 24/7 advice, but importantly it's access to the medicines that might be needed at the end of life. And in the places where we're really seeing integrated, proactive palliative and end-of-life care, that involves community pharmacy, it involves having the drugs that might be needed ready and available in the patient's home, so that if it's needed at night or weekend, a syringe driver, for example, can be set up there and then. And those
finally,
things are really
I mean,
important.
as well as the patient, there's also the family around the patient in the home, and the expert panel identified that about nearly £29 billion is effectively the value of unpaid carers in support of those providing in need of end of life and palliative support. Is that going to be part of your MSF? Is your MSF going to be integrated with those other services, including the DWP, to make sure that unpaid carers get the support that they need? Because otherwise, it's going to be a great deal more expensive to provide these services.
Well, unpaid carers have a voice in the MSF. That's one of the name of the organisation escapes me now. That's one of the main voices for unpaid carers. Is it? They're one of the voices that are in the MSF stakeholder engagement process. We also are very proud of the fact that we provided the uplift to carers allowance, the largest uplift since the scheme was created in the 1970s.
Liberal Democrats were delighted, yes. The Liberal Democrats were delighted, absolutely.
The Liberal Democrats were very pleased with that as well, I'm sure. And that I also chair a cross-departmental working group, if you like, with DFE because of young carers, DWP because of exactly the social security dimension to this, and DBT because of the employment side and trying to encourage employers to have a more progressive approach to unpaid carers. So we hugely value the role that they play. They're the lifeblood of our care system actually in this country, and we have to do more to help them.
So the DWP are very committed to supporting this agenda. We do have what we call special rules for the end of life, where people are approaching the end of life. They are fast-tracked in effect for certain benefits so that they don't have to wait or go through all the assessment processes. And that actually is very helpful for enabling people to get care in place quite quickly.
Thank you very much. Oh, very quickly.
That assessment of family carer support needs and support to address those needs has already been identified as one of the evidence-based interventions for the modern service framework.
Okay, thank you.
Okay. I mean, a lot of stock is being put into this modern service framework. I'm desperate to see it now. But can I just come back to the community pharmacy point before we move on? So you've outlined what we need to get to. How are we going to achieve that? I mean, community pharmacy has been struggling over the last few years. Are we looking to have a on-call 24-hour pharmacy where people, is that the vision? What's the vision here? And I'm assuming they are being closely consulted with as part of this as well?
Yeah, we have the pharmacy quality scheme where pharmacies are under the community pharmacy contract. They get certain payments based on their quality criteria, and one of those is palliative and end-of-life care. So do they stock the 16 what would the right word be? End-of-life medications. And if they do, they qualify for that under the community pharmacy contract, and then they're monitored on the basis of actually being open and accessible and delivering those services to people who require
it should already be happening, is what you're saying?
It's happening in lots of places, and it shouldn't be taking people by surprise. So we're not expecting pharmacies to open up at 1 a.m. and provide these drugs. We are expecting people to have anticipated the need, and some patients might have a sealed box with those drugs in their home for some weeks, because we anticipate that we could need them at any time. And so sort of just in case boxes are available. So it's about involving community pharmacy in the preparing of that and being ready, anticipating which patients are going to need those sorts of supports and having it there.
So this is linking back to the end-of-life care plan, except, okay,
absolutely.
I understand. Yeah. Thank you. Joe Robertson, please.
Thank you. Morning, Minister. Morning. The government published its 10-year health plan over the summer. It didn't contain a workforce plan, so you're writing one. It didn't contain a palliative care end-of-life plan, so you're writing one. It didn't contain a social care plan. Are you writing one of those?
Well, we have the Casey Commission, the independent commission that is going to report this year in terms of its first piece of work around defining the National Care Service, defining the standards and goals that we need to see through the National Care Service. And then, of course, there'll be a second phase report which will look more at the funding of adult social care.
Turning to a report that we know is coming out this year, or you say is the workforce plan. It's obviously a workforce plan across the spectrum of health and social care, we hope. Can you give the committee an assurance there will be a specific part of that dealing with palliative and end-of-life workforce?
I think the workforce plan is going to look at the different, if you like, professions across every aspect of the workforce. So palliative and end-of-life care will absolutely be covered in that process. But my colleague Karen Smith is leading on development of the workforce plan, and obviously it's all being quite sort of closely guarded, if you like, until publication in the spring. I don't know if colleagues can say a bit more about
I think it's worth saying the vast majority of palliative and end-of-life care is provided by primary care and by community nursing services, and obviously those teams provide a whole range of care, so narrowing it down to a specific aspect of what they might offer to patients is quite difficult. But what we do need to recognise is the impact of shifting and focusing more on palliative and end-of-life care on what the workforce capacity requirement in both community nursing services but also general practice will be, and those are very much part of the workforce plan.
Yeah, I wasn't asking a question about the way in which it'll be presented or the way it'll be formatted, but I'm looking for assurances that the specific needs within end-of-life care, palliative care, will be dealt with in the workforce plan. Clearly there is a need on general staffing, as there is across the whole of health and social care. But how will the workforce plan seek to address specific workforce needs and indeed specialist workforce needs for end-of-life and palliative care?
Well, if we take GPs, for example, what we currently have the GPWER, the General Practice Extended Roles skill, which defines what skills and capabilities and standards to which a GP should be able to work when it comes to dealing with a patient who is needing palliative or end-of-life care. So that would be, I think, the basic building block for looking at how GPs are going to be trained, have the capacity that they need, have the skills that they need to do palliative and end-of-life care beyond what you might call just sort of, no, I don't mean just, but what you might call pure and simple core GP capabilities. That will be the same for district nurses, for adult social care workers. What are the training and personal development plans and programs that need to be put in place to say, you know, you are a generalist, district nurse, GP, adult social care worker, but these are the specific skills and competences you need for palliative and end-of-life care. So what the workforce plan will do will be to define what are the additional skills and competencies that generalists need. And then, of course, on the specialist side, well, that's advanced clinical specialism, the just discussing with Mr. George in terms of the 910 specialist palliative care doctors that we currently have in the country.
But in terms of the modelling, so to get to the answer, there's a combination we need of what is the clinical model of care, and the clinical model of care is what we've been describing, and what do the demographics tell us is going to be the volume of need, and therefore how does that model up to what workforce you need, and that is absolutely being taken into account in planning.
It sounds like from what we're hearing that however it's presented, there will be considerable detail within that workforce plan about how we meet the needs of end-of-life care and palliative care. Can the committee take that as a given?
That I can confirm that will be taken into account in the modelling. What I'm not sure is whether it'll be presented as a separate detail section, but it will be counted.
And I think what the long-term workforce plan will contain is part of the discussion has been around the shift to out of hospital. And certainly within the kind of the 3-year guidance that's just gone out to the NHS just before Christmas, there is a really strong steering that, almost an instruction to start considering how you shift to provide out of hospital. And it says there are 2 priority cohorts for that, frailty and end-of-life care. So it'll be that shapes the long-term workforce plan. So I think it's inconceivable that there won't be something on there on end-of-life care in the context of neighbourhood health service and how that's provided to the workforce.
Given that health and social care is awash with plans and strategies, indeed there was a workforce strategy from the last government that was put aside for the new government strategy that hasn't come in yet, and the modern service framework may not be available until the autumn, and we know how deadlines slip. Can the Minister give some assurances that regardless of when various plans will be published, that the work to address issues is already happening, and given the context of today's discussion, particularly in end-of-life care and palliative care?
Absolutely. I mean, if just taking your point about the adult social care plan, we're not sitting in our hands and waiting for the Casey Commission to report. We have done the uplift for unpaid carers. We're working on a revolutionary fair pay agreement for adult social care workers to address vacancies in the workforce. We've significantly uplifted the disabled facilities grant. So that's an example of work going on. We recognise that there are some big strategic pieces of work that need to happen that take a longer time frame, but at the same time we've got to keep delivering and improving the quality of services. So that all of that work continues. We are looking to improve palliative and end-of-life care every single day, but what we believe that the modern service framework will enable us to deliver that step change.
Thank you, Chair.
Thank you very much. Danny Beale.
Thank you, Chair. Good morning. The independent expert panel's report emphasised that 1 in 4 people in the UK die without the services they need at the end of life. But for certain population groups, this is particularly the case, and disproportionately there's unmet need amongst groups that experience disadvantage throughout their lives. So, for instance, ethnic minority populations, babies, children and young people, individuals with dementia or other mental conditions and learning disabilities. You touched on inequalities in your opening remarks, Minister, and we've talked quite a lot about the differential performance of ICBs. Has an ICB-led commissioning process with a lack of clear national oversight contributed to this issue of unmet need and disproportionate outcomes?
Yes, I think that one of the reasons there's been fragmentation and inconsistency in the delivery of services and in tackling inequalities has been because there hasn't been a national set of standards and goals, and that is what the MSF will seek to address. We know that improving services for underserved areas is an integral part of the model ICB blueprint. So we've very clearly said to ICBs, you are not doing what you should be doing if you're not improving services for underserved areas in particular, and that is a very clear priority within the model ICB blueprint.
Will the MSF specifically deal with inequalities and outcomes? Will that be a specific focus of the MSF, do you think?
Yes, because the strategic commissioning piece of the MSF, by definition, I think strategic commissioning is about tackling, improving services for underserved areas. Because what you're saying is, with the finite resource that we have, where should that resource be prioritised? It's absolutely clear that it should be prioritised on underserved areas, whether that's geographical areas or underserved communities, either socioeconomic or ethnic minorities, for example. So the strategic commissioning will fail unless it is addressing underserved areres.
So that's welcome to know that the MSF will specifically deal with the inequalities that are present in palliative care. In terms of how that MSF will have bite, I suppose, that will lead to change. We've referenced standards at different points today already which exist, which are not implemented. You talked about the data, which is really vital. It'll be really important to judge the progress on inequalities, the data dashboard, but you mentioned participation is patchy. What is the carrot and what is the stick if that doesn't change, if participation in the data dashboard doesn't change, if the adoption of current standards doesn't improve, if the MSF doesn't deal with delivering practical progress and change? How does accountability work?
So every year, the ICBs have to provide officials and ultimately ministers with a report on how they have discharged their functions, based on the agreed targets that they have, the quality of patient outcomes, quality of access, the huge kind of panoply of targets and agreed outcomes that we have with the ICBs, and officials then hold ICBs to account on that basis, on the basis of that annual report. Clearly, you also have the CQC, which is an excellent tool, I think, for us. It's certainly improved a lot in recent months, I think, that helps us to hold ICBs and local authorities to account.
So where in that system is the failure? Because the level of inequalities that we see, the standards not being met in palliative care, it does feel like there are ICBs which are not currently fulfilling their responsibilities. I don't know if you agree that that's a fair assessment, and if that is the case, where in that accountability, if the mechanisms already exist for accountability, why are they not being taken? Or what level is it? At CQC level, is it, as you say, once the reports come in from ICBs showing these issues?
It's an excellent question, because I think when you've got such a complex system, accountability is one of the most difficult things to achieve. But you do have, if you look, for example, at the way the CQC works, if there's a local authority that's not doing what it should be doing in terms of adult social care, it'll go into special measures and requires improvement, grading, and then a team is sent in and they've got 6 months to turn it around. I don't think we are where we need to be in terms of having accountability of that level and of that robustness with regards to ICBs, but maybe Amanda
is the MSF going to be setting very clear metrics, I suppose?
The MSF will set very clear expectations around interventions, timelines, metrics, but we'll measure that as part of our oversight and assurance process, in which we measure ICBs, and we have regular meetings through our regional teams looking at progress of ICBs and where ICBs are outliers, looking at what improvement support. So some ICBs we have improvement support in place, looking at where focus needs to be. And so that process will be ongoing, and using some of the expectations that the various publications like the MSFs, because don't forget this is not the only MSF, but where ICBs are delivering against our expectations and within the round of the range of issues we're assuring ourselves on.
Yeah. And if those metrics are therefore not met, what will be the difference in action, and what will be the result of that, which is different compared to the current situation where standards we've heard are in place which are not met?
I think there will be, we are placing greater focus on the process by which we not only measure, but not hitting standards really is a trigger for a series of questions, because the reasons for not doing that will be different in different places. So it's a trigger for us to ask the detailed questions, or for our regional teams who are largely responsible for performance assurance around ICBs and providers, to start to dig more deeply into what's happening in individual ICBs. And obviously each ICB is starting from a different position, making sometimes really quite difficult prioritisation decisions, and it's important that we assure ourselves that they are prioritising the areas which we have agreed are key priorities for development.
Thank you. Turning to children's palliative care specifically, which is one of the areas where inequalities exist, I recently heard about it in the report. I visited Shooting Stars Hospice, which serves children and families in Hillingdon, but as many children's and young people's hospices, they serve quite large footprints because of the population size. I think 3 ICBs are meant to commission services for Shooting Stars Hospice, for instance. Children's palliative care is quite different to adult palliative care. Children and young people can be using the service for years, potentially into adulthood. As I say, the geographical footprints are quite different, and the family's involvement also more complicated. Will the MSF respond specifically to the issues and different challenges that children's palliative care faces?
Yes, absolutely. There are a number of key players in the children's palliative and end-of-life care sector, including, of course, Together for Short Lives, that have got a strong voice in the MSF development process.
Be a specific section or specific expectations and standards that are kind of specific to that sector within the MSF, so it won't be a kind of generic set of measures for all palliative care, but there'll be specific reference to the issues of children and young people.
I'm not looking at Sarah, but I'm assuming...
I think we should certainly be paying attention to the nuances around children's palliative care. I have a PhD in children's palliative care, and I'm really cognizant of the challenges in that space. I think it's not just babies, children, young people, it's antenatal palliative care as well, and we need to make sure there's specific focus on transition to adult services, including the role of that whole, the whole healthcare system to support those children and families.
So is that, just not to push you, but the words were slightly loose, so will there be specific sections, specific metrics, specific mention, rather than just paying attention to? Will there be specifics in the MSF?
We will be guided by the evidence that exists, and one of the challenges in this space is that the evidence base is less than in the rest of palliative care, but we'll be working with academic stakeholders and our partners in order to set those standards.
On transition, you mentioned briefly, it is an increasing issue that the sector reports as medical advances. Children are living longer with life-ending conditions, and they're transitioning into adult services from children's palliative care. That's often quite a leap, going from a children's service to an adult palliative care service where most people are usually in their 60s, 70s, 80s, dementia. They're quite very different facilities often where the care is provided. Do you think there needs to be more of a focus about coordinating suitable transition services?
Yes, I do, and we're leading research at Leeds around the role of the whole system to support those children and young people and their families at transition.
Would that be something picked up in the MSF, do you feel?
Yeah.
Yes, I think it will have to be. Yeah, it's clearly an area that needs more work.
That's helpful. And just lastly on children and young people services, as I mentioned, the service I met covered 3 ICB areas. We've already heard about the challenges of ICB commissioning, but the children's sector this is particularly acute because they're dealing with multiple ICBs, usually different commissioning arrangements with all of them. Do you think there's a case to look at whether there needs to be greater coordination of commissioning for children and young people's palliative care?
It's actually a really good example of why we need those national, coherent and consistent standards and approaches and goals, precisely then, because even if you are a children's hospice and you're having to deal with 2 or even 3 different ICBs, you're going to be getting a very similar approach from each of those ICBs rather than from the very fragmented landscape that you see at the moment. So it's actually an excellent example of why we need the MSF, and we need those more coherent and consistent approaches. So yes, I mean, I think that I think is a really important part of why we want to get that consistency.
Amanda wants to come in.
There are lots of services, or several services, whereby ICBs need to jointly commission because the volume of patients affected is much, much smaller than for more general services. And so we're setting up specific formalised pan-ICB commissioning arrangements within regions for those services, largely specialist services, but this is a good example.
Would a similar arrangement be suitable for
children? So this is the sort of thing that the pan-ICB arrangements will be appropriate for, and we are formalising that because we recognise it's very important for a small number of services, largely very specialist services.
You'll be able to provide information to the committee about when that arrangement will be established for children and young people's palliative care, that pan-ICB commissioning arrangement?
And certainly send more information about pan-ICB commissioning approach.
Okay, so it's not yet in train for children and young people's palliative care.
So we're starting to put it in place as part of the changes for ICBs and the changes for commissioning as part of the abolishing of NHS England requiring shifting of commissioning. So there are specialist commissioning services largely led by NHS England now, which will be delivered jointly by ICBs in the future.
Yeah, so there's obviously the move of specialised services on that basis. So this is an existing ICB commissioned service at the moment. The challenge at the moment is that there isn't coordination, and so I think the sector have pointed quite strongly to measures like this, joint boards of ICBs, requirements on joint commissioning, even national commissioning is something they suggested. So I just want to push on it because we often hear kind of positive ideas, but is there any timeline where changes might take place on that basis?
I'll send you information about the pan-ICB commissioning approaches and when they are likely to. It's in train.
Okay, it's in train for children and young people's palliative care.
Well, it's in train for the services which need to be commissioned across ICBs. Yeah. And this is an example of the sort of services that single ICBs
we're kind of talking about some services hypothetically. I want to get to a sense of, are we talking about children and young people's palliative care? Or we're not, which is fine, but I guess I'd like to understand what the timeline might be for considering whether children and young people's palliative care should be commissioned at a shared ICB level.
And that's for the ICBs to decide, but the structures will be in place to enable it. At the moment, what you often see with the sort of service you're describing is that one ICB commissions it on behalf of 3 or 4 ICBs.
Yeah, at the moment, the children's sector reports, at least that I've seen from Shooting Stars, is actually they have to have separate conversations with all different ICBs who are making separate decisions about palliative care for children and young people, which is very hard to plan workforce and facilities, and obviously young people and children don't necessarily follow ICB boundaries in their lives either. So you'll provide some general information, but do you feel that the MSF, this is an issue that the MSF could pick up around the need for coordinated commissioning of children and young people's?
So one of the things the MSF will look at is commissioning arrangements.
And I just,
very much.
A quick follow-up.
Just clarify on that, because there's a lot of, it's quite broad. I want to be very specific. I think this is one of my colleagues raised one of the most important points. Palliative care, children who long life-limiting or life-threatening conditions who need palliative care, who may live into their 30s or 40s, they are different, as my colleague said. Have you clearly got that difference written down and accepted and understood, and are you explicitly going to provide different nature of services, or just say, well, we'll look at it when it comes to specialist commissioning, and I hope you'll be glad with what you see there. But is there an explicit recognition in the department that children's, young people's palliative care is different from adult palliative care?
There is a specific NHS England. There are 2 different service specifications from NHS England. One is on children's palliative care and one is on adults' palliative care. So there is specific recognition. I think they were updated in the last couple of years. Sarah will know better than I do. But there is definitely different service specifications, and they kind of define and set out what are the good characteristics.
That will bleed through. That definition will be repeated and will bleed through to the work that all the guidance that you come out with, and the framework and all that stuff. You're going to make the difference explicit in the 2, or is it going to be sort of palliative care as a whole and children may not specifically be mentioned, whereas I think the point we're making is children and young people have to explicitly be mentioned. Children are already the poor relation in the NHS generally, but when it comes to children who have palliative care needs, that's even more the case. And we're just making an argument that you spell it out at every stage in everything you produce, that there's a distinction.
It will be explicitly a separate reference separately in the MSF. The commissioning arrangements, of course, it's only a very small part of the commissioning that might need to be done across more than one ICB. So you've given an example of a children's hospice, I think it is. But most commissioning is very local commissioning of services to children and their families. But it is different from adult palliative care, and that will be made explicit.
Thank you. Paulette Hamilton.
Good morning. Good morning, Minister Kinnock. I'm going to be talking about rural palliative care and hospice care. So my first question is following on from what Danny's been talking about, the diversity when you look at people that live in rural areas. The fact that these people, the research is there to show that they struggle to get any form of palliative care. They even have further problems getting hospice care, and their outcomes tend to be poorer. What is the government going to do for, I believe, this very special group that does need to be looked at for the future?
Yeah, I think one of the crucial issues here is that the data on inequality of access is not very robust. So we've got the Policy Research Unit, which is within the NIHR, that is doing a deep dive on inequality and trying to give us a much more robust data set around geographic inequality, socioeconomic inequality, and inequality along ethnic lines. So I think the first answer to your question is we need to get much better data, and that data I think will help ICBs and commissioners to do what they are required to do. The model ICB blueprint is very clear that a priority of every ICB must be to prioritise underserved areas and underserved communities. So there is a very clear ask of every ICB to prioritise underserved areas, but there is not good enough or robust enough data on identifying those communities and those areas, and then commissioning work which actually delivers accordingly.
I will stop. That is a really good point for me to move into my next point around hospices. Let me start by saying the 25 million that has been announced, fantastic, fantastic, fantastic. How did you get to that sum of money at this point?
So the 100 million...
So was it?
Yeah.
Which sofa was it?
Yeah, it was... I would never put it in such undiplomatic terms, but
considering you've just talked about data, how did you get to that?
Yeah, look, I'll absolutely upfront on this. We have a capital budget right across the Department for Health and Social Care, and where there are opportunities for spotting an underspend in a particular area of activity, it's my job to go in, roll up my sleeves, and fight like hell for my portfolio. And a top priority for me in doing that is hospices. I was very pleased that we managed to get the £100 million, and now we've added £25 million to that, and the £80 million over 3 years. I think it's really helped children's hospices.
But
they've got now they no longer have an annual cycle.
I'm going to stop you there, Minister, because the £80 million it's revenue, so it means that is recurring over 3 years. The problem with capital, you give that money once, people feel they're out of the crisis at one point, but within 12-18 months they're back into the crisis. So going forward, you've talked about the fact that hospices they are a key part of your priority. You've talked about whenever you can find money, you give it to them. You've talked about the MSF framework today. You've also made absolutely some fantastic references about you not wanting hospices to really come under the NHS. Do you not feel that what you have actually done is you have put ICBs in such a stranglehold to say they've got to deliver on all of this, that you've set them up to fail? The fact that you've taken 50% out of their budget, they have got so many other priorities, but you're now saying they've got to absolutely find the data, they've got to do the strategic commissioning, they've got to deliver on all of this. How is that going to work?
I think we are definitely setting the system a challenge to work more effectively. But our view is that by doing strategic commissioning more effectively, by getting that better understanding of the health needs of your population, by creating a robust strategy and bringing all of the key partners together, including the voluntary sector like hospices, you're going to drive up efficiency and drive up productivity. So by working more smartly, you can deliver what needs to be delivered without necessarily having all of the resources that you have right now. I also think improved technology can play a major part in driving up productivity and efficiency.
So going back to NHSE and that new department that's going to be set up, do you not think, especially with hospices, in your vision, you're wanting them to remain in the charity sector, that they will have a role relating to data as well as ICBs?
Yeah, I think absolutely. I mean, hospices on average receive about 30% of their funding from the state, from the NHS. So, they are a really important partner for us, but they're a kind of hybrid model of some state funding and then what they raise through charity. And therefore, we see them as an integral part of what we want to do on commissioning and the way that ICBs work. And we need them to feed in data. I think that is one of the challenges with hospices, because they're not 100% part of the system. We don't always get all of the data that we need, and Sarah may wish to comment on that, but I think that's partly about bringing ICBs into the hospices into the beginning of the conversation, rather than sort of coming to them halfway through and saying, oh, by the way, we need this from you, we need that from you, and you haven't really developed that relationship and that partnership from the outset. So Sarah, I don't know if you want to say something on data and the role of hospices.
Just as we move forward with the MSF, I think data that helps us understand outcomes for patients and their families is most important, and hospices are absolutely key partners in how we come together and make that data set. They already do have a lot of good data about their activity, how many patients they're managing to meet in the community. Some of the palliative care outcome scores are in use more widely in hospices, and we can follow their example across the rest of the system. So yeah, I think the data can be much more.
But I would beg to differ, if you don't mind me saying. The fact that we have given this sum of money to hospices, how as a government are we ensuring that that money is being distributed in a way that it's needs-led, because it's data-driven? Because at the moment I can't see how that's being done.
Can I just
say sure.
So by their nature, in terms of where I think you're attending the Public Accounts Committee with us next week, aren't you? So
I am attending.
So you've seen the report that kind of shows the distribution of them.
Yeah.
But by their very nature, because they kind of emerged so unsystematically, there's an inequality inherent almost about where hospices are kind of situated. I think they vary between 1 and 13 hospices per ICB. So that's just kind of part of the makeup. They are not the only part of palliative care, obviously. You've got to commission the service. So in the ICB where there's only one hospice, the ICB has to be commissioning the care that is required otherwise. In terms of how they're funded, there are basically two different ways of them being funded at the moment. Some of them are getting grants, which is the traditional way. Some are starting to move on to more activity-based payments.
I'm going to stop you. We know how they're funded. My issue isn't around how they are funded. My issue is about, we are giving money to hospices, which I absolutely support that we do, but how are we, what is the work that's being done under that to say where that money is going, what is that money for, and how as a government can we ensure, even with the MSF framework that we're doing going forward, that we are being fair and equitable? Because the example I'm going to give is in my local area, we've got a wonderful hospice. They've lost 50% of their staff, something of that kind, because they've not had enough funds, right? When the local ICB realised that they were, they started to tell them they were in trouble, they did give them some support, just like the government has given support. But what I'm trying to get at is, how are we ensuring that we have the right data to make sure the right hospices are getting the support they need, and it's not just a scattergun effect, which means that in some parts of the country, like York or Oxford, where people have lots of money,
we have our own issues.
They leave very expensive properties that they are able to survive. But other areas where you're not getting all that charitable funding, that these organisations continue to struggle, even with the MSF framework that's coming on board.
One of the things I was going to say, that traditionally they're funded by grants, but part of the shift with lots of them and the push for the strategic commissioning framework is, can you move to more like activity-based payments so they are getting fairly remunerated for what they do, and how do you start to generate that data about what they're doing? Now, there's some hospice I know that, it's complex. I know one hospice, for example, that's commissioned by 2 ICBs because it's near a border. One of them gives it by a grant and the other one gives it by an activity payment. But the activity payment starts to reflect more fairly and accurately what they're doing. So that is the bit that Minister Kinnock was talking about, that the kind of this, how do you kind of ICBs evolve as kind of smarter, more strategic commissioners who are fairly paying for it. So I think a lot of it is about, we're in a kind of point of transition, I think, in terms of how a lot of hospice is being paid. So the Leeds example, St Gemma's Hospice, they are kind of moving towards trying to get paid by activity, exactly as you're kind of getting at. So, but not everywhere's there. So I think there's quite a mix, and there's quite a challenge to get everyone in that place. They're getting the fair payment.
So what is the government doing to get everyone to that point? Because I am concerned that leaving it all on ICBs, you're setting yourselves up to fail. I'll be honest with you, because of the issues they currently have within ICBs, with some of the major cuts that they've got to do, the fact that you're joining up a number of them, so they become having bigger footprints, which go across some of these different hospices. What is the government doing in their strategic position to ensure that hospices are protected going forward, and they are not just being given pots of money as government finds a little bit down an armchair? And I don't like saying that, but yeah.
I think two things. I mean, I think, Paulette, you raised a really important point about, is the money going to the communities and parts of the country that need it most? And we are actually looking at the funding formula, the core allocation formula for ICBs, to ensure that it's aligned with socio-economic need. Another example of that is, of course, the review we're doing of the Carr-Hill formula to ensure that GPs in most deprived areas of the country are getting. At the moment, that formula doesn't work at all. That's why we're changing it. So the government is absolutely motivated by saying, look, we have a finite resource. We need to make sure that resource is going to the parts of the country and to the communities that need it most. And the second part, I think your question is about not just kind of giving money here or there willy-nilly without really thinking it through. On the 125 million that we've given to adult hospices, that has been coordinated through Hospice UK. They have done a needs-based assessment of the projects and proposals that each hospice has had on, do we need the boiler fixed, the roof fixed, the IT infrastructure upgraded, because that is capital expenditure. And Hospice UK, I think, have done an excellent job in terms of understanding what the needs are and making sure that the money that's been given, and has all been committed, by the way, has gone to good projects that are really going to help to upgrade the capability for the long term for those hospices. So I think there's two parts to your question. One is, let's make sure that the money is distributed across the country to the ICBs that need it most in a fair way, a fairer way. And the other is about that money we've given to hospices so far and how that's been coordinated.
My final point, and then I'll hand back to the chair. It's about staffing. Staffing is a major issue within hospices. Capital funding is not normally used towards staffing. So how are you supporting hospices to ensure that they're not still losing staff, because the money that you're giving them is absolutely, it cannot be used towards staffing?
Yeah, so obviously on the children's hospices side, that was revenue funding, so that's for staffing. But on the adult side, well, our view is that, you know, when you look at the ledger for any hospice and the income that it has and the expenditure that it has, if you can help with expenditure on the capital side, those projects about fixing the roof that just have never happened because the budget's been too stretched, or where they've vitally had to do it and they were going to have to take money out of revenue to put into fixing the roof, by giving them funding on the capital side, we've taken the pressure off their entire budget. So our view is that even though we were only able to find that money in the capital side of our ledger, that has helped to ease cost pressures right across the board for the hospices.
I will stop there and I'll hand back to the chair in case you want to ask.
Thank you very much. We're very nearly done, but a question that's come to mind through this for me is just how much heavy lifting this MSF is going to have to do. And looking at the 5 areas that you are planning to have them in, we've got frailty, dementia, mental health, of course. So actually, these are 4 areas that the committee's already taken a keen interest on, has done inquiries in. And the reason we've done that is because they are quite intractable issues that we feel need fixing. But I'm struck that there is already, you know, a palliative and end-of-life care standard updated November 2025. Are these MSFs just another way of kicking cans down the road? And what's going to be different in these that is actually going to make it? I'm not sure I'm still clear on that in this. So let's just take this one, because this is the first time we've had a chance to interrogate and understand them a bit better in this specific context. How can you assure me this is not just another kicking the can down the road on a really difficult problem plan?
I think it's because it's part of a systemic shift which is set out in the 10-year plan. So it doesn't, the MSF is not going to exist in isolation from all of the other change that we want to deliver. That is articulated in the 10-year plan, and that makes it very clear to the entire system. And I do think the entire system has understood this.
Why do you need an MSF? You've already got the standard and you're doing the shift. So we agree with the shift and we think the standard's right. I mean, you know, by and large, people just want it to happen. So what role would specifically the MSF be playing in making this work? Why do you need it? Why have you done this?
A big part of it is because of the stakeholder engagement that we've got through it. So there's going to be an entire system that's going to come behind this. It's not just something that we're developing in isolation. And I think the other is that we've identified the fact that there's too much fragmentation, each ICB going off and doing its own thing. The reason we need the modern service framework is that there isn't currently a national plan, a national set of standards and goals that every ICB and every other stakeholder in the system understands that this is what is expected of them and that they will be held to account on that basis. So it's about, you know, saying, okay, we're going to have strategic commissioning, we've got the model ICB framework, but this is a real priority for this government, is palliative and end-of-life care. That's why it's one of only 5 modern service frameworks. I think that sends out, if you like, a bat signal to the entire system, which is that palliative and end-of-life care is a top priority of this government. We need to fix it, and the MSF is going to be a way of mobilising the system to do that.
It's a reprioritisation exercise in part. Are we expecting new standards, or is the current standard just going to be sort of subsumed into the MSF? Is that how it's going to work?
I don't want to preempt, and it's so important, I think, that we co-produce this with the stakeholder group. Already 5 meetings have taken place, and I think that there'll be an answer to that question.
You sit on those meetings?
I don't, no. It's officials and stakeholders.
It's an official level.
I get regular updates from officials, and I'm pretty sure they'll wheel me in at some point, but not yet.
Thank you very much. That was very helpful. Thank you very much all for coming. I also want to put on our public thank you to Jane Dacre, the team at the Independent Expert Panel, the excellent report on which we've based all of our questions today, and we'll be writing our own recommendations report off the back. Some of the specialists are in the room and have watched the whole session today. So thank you very much to them for their incredible work. Thank you all. Order.